Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. Natalia asked, do we use mouth gags? You don't see any in videos. That's a good question about the videos. I guess most of the time when we're doing the videos, we've got it in on the spot that we're actually doing the procedure. Many times I do use mouth gags, and the mouth gags are out of syringe barrels. So we know they're not spring-loaded, which we know can slip and cause some severe problems. They are cut in multiple lengths, and then those lengths are fitted where we know we're starting to get resistance with the patient's mouth when we open, and then we never open it all the way. We just know where we're starting to get resistance, and then we open them a little further and then put the mouth gag in, and that serves as a gag. You can do that with cats with a tuberculin syringe, with a 3cc with dogs, 6cc syringe with dogs. We also use endotracheal tubes in real big dogs. So we cut like a 10 endotracheal tube or so and use that between canines. There's also some little styrofoam gags that you can buy that you can use in the back, in the premolar area. That will help quite a bit as well. But yes, we do. We do use gags, and only rare videos now that are out there now that I have are cadavers. And you can tell pretty much by the color of the gingiva. So most of our videos are live, and we may or may not use a mouth gag in them, but I do use them quite a bit in surgery just to get better exposure. And when you think about one of the times that you want to use a mouth gag would be if you're working back in the caudal oral cavity trying to do a fourth upper premolar extraction, first molar extraction, because what's going to happen if you don't have that mouth open, the head of the burr is going to interfere in the opposite arcade. So you're not going to be able, you have to open the mouth to get the burr in far enough so that you can have good access to the tooth you're working on. So that's one big instance where you would definitely want to use a mouth gag. Tips and tricks for incisor extractions. Not very comfortable with flap preparation and closure. Had 2 times where suture failed. In general, Michael, to answer that question, I don't recommend doing flaps in incisors unless you fracture a tooth. I recommend you do simple extraction technique and not do a flap, because those flaps are very narrow based. They require quite a bit of manipulation to mobilize them, to get them to close over the lingual, or in particular the palatal side of a single extraction. So I would not recommend doing that. Now, if you have multiple extractions, like in a case with perio that has the marginal gingiva is really inflamed, then all that tissue is going to be fimbriated. It's not going to be tightly adhered to the bone like it is with a, say, fractured incisor that you're extracting. There's going to be less bone, so it's not going to be as hard of an extraction, but the tissue is going to be pretty nasty when you're done. So what we recommend there is just going down with a scissor and straightening both the lingual and the vestibular side, or the palatal and vestibular side, and then suturing that. After you've gone down in with your football burr, smooth the bone, got all the granulation tissue out, and just do simple interrupted closure there. So that's one case where we would recommend closing. The other thing I want to mention is if you are having dehiscence in that area, it probably is because the flap's too narrow and it's got too much tension. Those are 2 reasons why flaps don't work. The other reason is if there's no Elizabethan collar placed on the patient for 2 weeks to prevent self-trauma. So definitely want to do that. Definitely want to make sure there's no tension on there by dissecting. If you do break one, and you've got to get down in and get the root out. The other thing I'll mention along those lines when you have a lateral incisor, that's a hard extraction. And they're prone to get fractured when you have canine tooth fractures as well. Often that one is fractured too. Those are, as in most cases, long, thick, and curved roots. They're in more cortical bone than the other incisors, and so they're much more difficult to extract. We recommend doing most of our elevation on the mesial and palatal side on those, but if you use the Vetome is a mechanical periotome that is a flat blade that moves very quickly up and down on a handpiece that is regulated by a foot pedal. In doing so, it will go down between the bone and the tooth root and create an enlarged periodontal ligament space. And if you go to Dr. Brett's Pets, go to the Vetome, which is under equipment, and there's a video that shows the very first time I used that about 3 years ago, where we used that on a lateral incisor in a large dog that had no perio, and we didn't even use elevators. And many times we don't need elevators. We just use that, and we can go straight to the extraction forceps, and that makes many extractions, not just that tooth, but the lingual side on the mandibular canine tooth, use it on that. You don't have to take as much bone on the vestibular side when you do that in most cases. So excellent for that. We also use it, if we can, depending on the dog, because we use it on the lingual side of the mandibular first molar, if you can get it in there. Depending on the dog's anatomy, the bigger the easier, but on the lingual side of those two roots, and it makes that extraction so much easier as well. So if you're doing a lot of extractions, Vetome is cheaper on Dr. Brett's Pets than it is from IM3, who is a manufacturer. It's ordered directly through them, it's shipped through them, all the warranties are the same. We just have it for less than what they have it. So if you're doing a lot of extractions, you won't use it every day, but you will love it and not want to part with it. We take ours every time we travel to Orlando and Atlanta. I will not do extractions without it. And if we forget it, I don't think we have, but if we were to forget it, I'd be upset. It's invaluable if you're doing a lot of extractions. If you're not doing those teeth, if you're not doing a lot of fractured teeth, if you're doing mainly perio and you're not doing those teeth, then I would not even consider it. But for those of you who are, it's a practice changer if you're doing a lot. For Class 2 malocclusion, Kyle, would it be appropriate to extract mandibular canines if clients can't afford a referral? And let's qualify that by saying if this is a significant Class 2 malocclusion where you have a tooth-on-tissue or tooth-on-tooth contact, then the other options are preferred, and you can definitely extract the mandibular canines to resolve that. That's perfectly acceptable treatment, but you have to ask yourself, how severe is the trauma? If you are doing odontoplasty and bonding, which most of you aren't, you could certainly take that crown down a little bit if it's not too much into the tissue, and see if you can avoid and bond it. I don't know if I just said that or not. And bond it, and then extubate and see if you still have contact, and you may be able to avoid that profound extraction treatment. But otherwise, yes, if it's causing significant damage, the owners can't refer, and you're comfortable doing extractions on mandibular canines that don't have periodontal disease, which most people aren't, then extraction is a perfect resolution to that. But all in all, referral, depending on where you're at, probably not that much more expensive if it's a one-time procedure than it would be for extraction. But again, it depends on what you charge. You should be charging quite a bit, because that, in general practice, that should be probably an hour and 15 per side procedure. In specialty practice, it's definitely not, but in general practice, it may be. Good question. She's asking why that mandibular second molar that I mentioned was a difficult extraction. It's back in the back part of the mouth. It's in very thick cortical bone. Those roots are often curved, and it's difficult to access that if you fracture the roots. You have to be really careful in elevation. You have to be very gentle, firm but gentle. And again, that head loop comes in absolutely essential there, so you can see if you're moving the tooth so that you don't put too much pressure on it. And I generally recommend when you're doing that to start in the furcation after you section it and just use 2-finger pressure on that and just watch that tooth or watch those teeth separate from each other as you do that and get an idea for how much pressure you're putting on that in that respect and how much mobility you're getting. If you're doing this and getting zero mobility, that's going to be a hard extraction, and you might have to do a flap. If you do a flap, it's not a fun area to remove bone, because the deeper those roots get, the more thick the alveolar bone gets. So it's best to try not to do a flap on that unless you're already doing a flap on the mandibular first molar. And even then, I will try to section that and extract that tooth first without doing a flap, and see if I can get it out without a flap, even if I'm doing the mandibular molar. So try to do that first. If you're not, and a lot of times that tooth is coming out because of perio. So sometimes it's super easy. You section it and the roots are mobile. But if it's not perio, and we get this a lot with chronic ulcerative periodontal stomatitis or cups, where the teeth have not undergone periodontal disease, but all of them or many of them need to be removed because of the inflammation in the tissue next to them, but there's no bone loss. So that's a common presentation that we see, that we use often, and we see probably more often than you guys will. Most of the time you're extracting that tooth, it's going to be from perio. I hope you enjoyed this episode. There's a lot of actionable items in there that you can take and use in your practice immediately. So put those to work and enjoy the benefits for the practice lifetime in your dentistry service. So until next week, have a great week. Take care, guys.